All right, let's move on now to eyes in orbit. And we'll begin with surface anatomy. And now, just to get oriented here, this is the person's right eye. This would be lateral, this is medial. Nose would be right about here. And to begin with, of course, we have eyelids. And the term for eyelid in Latin is palpebra. And so the upper eyelid, right there, is the palpebra superioris. And the lower eyelid right here is the palpebra inferioris. Okay, remember adjectives always come after the noun. So upper eyelid, upper lid would be, in Latin you would say lid upper, palpebra superioris. And then the little slit here between the two eyelids that can open or close as needed is called the palpebral fissure. And so we look out through our palpebral fissures. Essentially, the palpebral fissure is the hole in your face that your eye looks out of. And then the eyelids are going to meet laterally and medially. And so what we commonly refer to as the corners of the eye are the canthi. And so where the two eyelids meet out here, the lateral corner of the eye is properly called the lateral canthus. And then the medial corner of the eye, where the two eyelids meet, that's the medial canthus. And then when we look at the eye itself, the white of the eye is referred to as the sclera. And the sclera gives rise, transitions here to form a new kind of tissue right here that's transparent, and that's the cornea, which is a transparent dome-like structure right here. That's the cornea, all of this. And the boundary between the sclera and the cornea, this border right here, is called the limbus. Remember from neuroscience, limbus means border, like the limbic system. Okay, this is the limbus right here, which is the border between the sclera and the cornea. And then deep to the cornea, we have some structures. For one thing, we have this big sphincter thing going all the way around right here. Usually has pigment associated with it, all different colors. That's the iris right there. And then that sphincter-like structure has a hole in the center called a pupil. And again, both of these structures, the iris and the pupil, are deep to the cornea. And then over here, going back to the medial canthus, just before we get to the medial canthus, there's that gross little globular-like thing in the corner of your eye right there. In case you're wondering what that's called, it's called your lacrimal caruncle. And this contains sebaceous glands that secrete an oil. We like our eye really, really oily. And there'll be a series of glands we'll talk about. The oil lining basically the edges of the palpebral fissure. That's designed to keep teardrops, lacrimal fluid, on the surface of the eye and not have it run out of the eye and down the face. Doesn't do a lot of good if all that lacrimal fluid drains out of our eye as quickly as we can make it. We want to keep lubricated here, and so there's a hydrophobic film all along the edge of the eye here that helps keep that aqueous lacrimal fluid on the surface of the eye, sclera, and even more importantly, the cornea, as needed. And the lacrimal caruncle is one of those glands whose job it is to do that, to secrete that kind of oil. And this is an FYI. You don't actually have to know this. Just thought you might be interested in what this thing is right here. If you look closely in the mirror, we all have this little edge right here, a little sharp edge right there, and a structure right there, just medial to it. Okay, this little edge right here is called your plica semilunaris. Okay, or a semilunar fold of the eye. Okay, we have semilunar folds in the abdomen as well. There's a different one. And this thing right there, next to the plica semilunaris, that's your nictitating membrane right there, your third eyelid. Okay, so sharks have them. When the sharks start chomping on something, either a fish or a person's leg or whatever, there's that third eyelid, that nictitating membrane that closes over the eye. When cats are sick, their third eyelid will close over their eye. Well, you've got one too. It just doesn't work. It's basically non-functional. This is the only true vestigial structure, in my opinion, in the human body that's just sort of left over, and it doesn't really do anything. But you do have a third eyelid, in case you're wondering. Again, this is FYI. I will not ask you a question about the plica semilunaris or your third eyelid or anything like that. It's just fun. Looking at the eyeball and sagittal section right here. Again, this outer white of the eye right here is called the sclera, and the sclera will transition to form this transparent dome-like structure called the cornea right there, and the limbus would be right there and right there. And then deep to the cornea, we have this structure, this like a sphincter-like structure right here called the iris that has a hole in the center for light to pass through. That's the pupil. And where the light wants to go is pass through this thing right here and strike the back of the eyeball right here. All this brown stuff back here is the retina, and that contains photoreceptors, which are able to detect photons, and they in turn interact or synapse with bipolar neurons, which in turn synapse with retinal ganglion cells, and it's the retinal ganglion cells that shoot axons into the optic nerve right here in the cranial nerve 2. This little spot right here is called the fovea, which is in the center of something called the macula lutea. We won't make a strong distinction between those two things. We'll treat them as almost synonymous, even though they're not exactly the same thing. Macula lutea means yellow spot, and the fovea is in the center of this. But this is the spot of maximum acuity in the back of the retina. Photoreceptors known as cones are concentrated here. There are other photoreceptors called rods that tend to avoid the fovea, but that's the point of maximum acuity right there in the back of the retina. And then right here, that's not to be confused with this other structure, this other spot right here in the back of the retina called the optic disc. The optic disc has actually no acuity at all. There are no photoreceptors in this one little spot right here. And what this is basically the beginning of the optic nerve, okay, which is right there, or cranial nerve 2. And all the axons from retinal ganglion cells throughout the retina, they're all heading to this spot right here, the optic disc, and they're all heading this way, and then they exit right here and go to the optic nerve, and they head on towards the thalamus ultimately. Okay, it's also through this optic disc that the vasculature of the retina enters the eye. There's something called the central retinal artery that's going to pass out, and then we have central retinal veins that drain the retina back. Okay, so there's vasculature as well. Okay, and then over here, I didn't really tell you what this thing was. So light's going to pass through the cornea, then through the pupil, and then it's going to pass through this structure right here called the lens. Okay, it's like a little stone inside your eye. It has a biconvex shape to it, meaning it's convex anteriorly and convex posteriorly. And then on either side of it are two separate chambers with a different kind of fluid in them. So here and here is a chamber that contains a kind of a watery substance called aqueous humor. It really is an aqueous solution, pretty similar to the water or cerebrospinal fluid. This is called the posterior chamber right here on the back side of the iris. This is the anterior chamber between the iris and the cornea, and that's filled with aqueous humor. And then over here on this side of the lens, all of this is filled with a gelatin-like structure called vitreous humor, and it really is like a little jello. If you open up an eyeball, it's looks like jello. What more can I say? And that's called vitreous humor right there. And those are separate chambers there. There's no continuity between the chamber containing the vitreous humor and the aqueous humor. Okay, that brings us to a reflex that we should know. And this is the corneal or blink reflex. And basically, this is a reflex where basically you're inducing the patient to blink. Generally speaking, we don't like things touching our eye. And when something touches our eye, we generally respond by blinking, by closing our eye reflexively. And so the test basically is take something obviously benign, like a little wisp of cotton right here. This is a little piece of cotton there that gets even thinner. And you can just make out right there, just the thinnest little piece of cotton right there. And you generally touch it right to the limbus right here. So this is the limbus, this is cornea, and this is sclera. And you generally touch this right to the limbus, and that should induce a blink if everything is okay. The nerves involved, okay, so again, like at most reflexes, there's a sensory limb to the reflex, or an afferent limb, and there's a motor limb or an efferent limb, and you're testing both those things at the same time. You're stimulating a sensory nerve, that's the afferent limb, and there's a motor response, or an efferent limb. And so there are two different nerves involved. The sensory limb, or afferent limb, is via the ophthalmic division of the trigeminal nerve, or cranial nerve V1. So the cornea and the sclera, basically the anterior surface of the eye. You kind of think of it as logical, it's part of your face, and sensory innervation of the face, of course, is by trigeminal nerve. And this lies within the V1 dermatome. Remember, the upper eyelid is V1 dermatome, lower eyelid is V2 dermatome. So right here, this is the boundary between a V1 and V2 dermatome, right here along the edge of the lower eyelid. And so we're stimulating the V1 dermatome, okay, and that's going to carry pain information. This is considered pain because something is not supposed to be touching your eye, back to the brain stem. Those of you taking neuroscience should be able to recite that whole trigeminal pain pathway right now, okay? It could come up again, okay? And then there's a motor response, and the motor response is a blink, and that's a muscle facial expression, specifically the palpebral part of the orbicularis oculi muscle. That's the blinker. That thing should twitch and close the eye reflexively in response to being touched right there. And so the nerve, that's the part of the efferent limb, then, is the facial nerve, or cranial nerve 7. And so this reflex, corneal or blink reflex, is testing cranial nerves V1 and 7 as a unit. If those two nerves are good, then there should be a robust, healthy blink that the patient produces in response to having their eye touched. So I want you to know this reflex. I want you to know the major components of it, how you induce it, which cranial nerves are involved, and what the muscle is that twitches in response, and then the contact point, most commonly, is the limbus. All right, so now let's talk about the conjunctiva, which is this stuff right here. So when we look at this, starting at the limbus right here, the sclera has this little mucosal tissue that's forming an anterior boundary right there that actually reflects onto the inner aspect of the upper eyelid. And we see the same thing down here. Again, the sclera is covered with conjunctiva that also reflects onto the lower eyelid. And indeed, if we were to close our eye right here and take the upper eyelid and oppose it to the lower eyelid and close this up, that would complete a sac all the way around. We could go from limbus to limbus here. So limbus onto the eyelid, jump over to the other eyelid, come all the way around to here. And it would create a little mucosal sac in front of the eye that helps to protect it and keep it moist. And so we call that the conjunctival sac right there. I'm having a hard time with this word today. I gotta keep moving on. Okay, conjunctivitis, okay, is inflammation of that mucous membrane. Bacterial conjunctivitis is very often called pink eye, and it's basically inflammation of this little mucous membrane right there. Okay, let's zoom in here just to make one little differential right here. There are two different kinds of conjunctiva. Of course, anatomists do this all the time. We gotta divide things up. We can't help ourselves. The stuff that's actually on the eyelid, so the conjunctiva that's lining the inner aspect of the eyelid, is called palpebral conjunctiva, right there, okay, because it's on the eyelid. And then that part of the conjunctiva that's on the sclera is called bulbar conjunctiva. Okay, that's it right there. Okay, so two different types I want you to distinguish, but otherwise it's a continuous membrane going all the way around. All right, let's look at a little bit at the osteology of the orbit. What is the orbit? The orbit is the eye hole, okay, or the eye socket, I think is what people usually call it. At least lay people call it. You should be calling it the orbit from now on. Just to get oriented, this is lateral, this is medial, because these are nasal bones forming the upper part of the nose. Okay, so we're looking at the right orbit right now. And basically, a whole bunch of bones make a contribution to the wall of the orbit. The roof of the orbit right here is formed by the frontal bone in blue. Sort of most of the lateral side of the orbit and sort of the inferior orbital margin right here, the ridge going all the way around here, is called the orbital margin, and kind of part of the floor, but most of the, or at least half of the inferior margin right there in the lateral side is all zygomatic bone. Remember, that's that high cheekbone out here. And then the other part of the floor of the orbit is going to be maxilla, which is the upper jawbone, actually. It goes all the way up into the orbit. And obviously at the other end of this thing, we're going to find teeth, but that's the maxilla right there, the upper jawbone. It forms the floor of the orbit. Medial side of the orbit, don't worry about this guy. I'm not going to ask you to know who this guy is right there. I'm not even going to ask you to know what this bone is right here, but I would like you to know what this gray bone is right here. And this is actually part of the ethmoid bone. Remember we talked about the cribriform plate and the crista galli, same ethmoid bone, also forms the medial wall of the orbit. This particular part of the ethmoid bone forming the medial wall of the orbit has a specific name. It's called the orbital lamina of the ethmoid bone, but it's also called the lamina paprizia, which means in Latin papyrus paper. And we'll talk about why it's called that in a second. The backside of the orbit, most of the backside of the orbit is all sphenoid bone right there. All of this stuff in yellow, and we can see a number of different openings. There's an opening there, opening there, opening there, in the backside of the orbit that gives access to that space. Okay, now let's go back to this lamina paprizia issue right here. The reason it's called papyrus paper, okay, in Latin is because it's very thin. In fact, if you look at a real one, a real skull, which unfortunately we don't have any real skulls, but if you look at a real skull, this bone is actually translucent. You can actually look through this bone at the next deeper structure, which are things called ethmoid air cells, which are little air pockets. The skull is hollowed out in various places. These are the air sinuses. When we talk about having a sinus infection, that's what we're talking about. Inflammation of the mucosal membranes of those little air pockets. Among those air pockets are the ethmoid air cells, and they're just on the other side of this bone. And this is so thin right there that you can actually look through the bone into those ethmoid air cells. Very, very thin. Also thin is this part of the maxilla that's forming the floor of the orbit. So all of this, sort of the medial wall and the floor, this is all pretty thin and fragile right here. And this brings us to an important clinical correlation right here, which is the concept of a blowout fracture, which is an orbital fracture. Now what can happen here is that this right here is a CT, a head CT, and you can see there's the orbit right there. Okay, the floor of the orbit, of course, again, is maxilla. There's the lamina paprizia right there, that part of the ethmoid bone. These are the ethmoid air cells actually right there. Okay, fun enough, there they are. There's the orbit. Below this, below the maxilla, there's a giant gymnasium-sized air sinus here called the maxillary sinus. Okay, it's huge, pretty much. Your cheek is hollow. If you go deep to that bone, you find this giant chamber here. It's just an open air sinus there. There's nothing in there but mucous membrane and air. Okay? And what can happen is blunt trauma to the orbit. So getting punched in the face or, not catching a baseball, having it go right past your glove and hit you in the face, or a motor vehicle accident. Any blunt trauma here to the orbit, what it can do is it doesn't always break the orbital margin, but the concussion of that blow can fracture either the lamina paprizia or even more commonly the floor of the orbit formed by the maxilla. And you can see what happens. The floor is fractured, bone fragments fall down. The orbit, like everything else in the body, is filled with fat. Okay, it's periorbital fat, so that's periorbital fat falling down through that hole, and the eye can even start to work down through that hole along with the muscles that move it. Okay, and that's a blowout fracture, and you can see it on this side, on the left side of the patient right there. This patient actually has a blowout fracture. You can see the floor of the orbit's been obliterated, and you can see a whole bunch of stuff hanging down into the maxillary sinus that ain't supposed to be there. And so the contents of the orbit are starting to fall through this gap in the floor right here. And that's the real danger right here. It's more than a black eye. A black eye is basically just edema of the skin around the eye, and that's much more benign. This is a much more serious situation. The bone is fractured, and the contents of the orbit are starting to fall through that hole in the floor, and that can cause all sorts of problems in there. So you don't want to miss this diagnosis. Okay? And so basically what's going to happen is that some of the complications that can occur, you can see the muscles can get entrapped, which means the eye isn't able to move properly. That in turn is going to result in double vision. Whenever a patient can't move one of their eyes efficiently, they start to see double because the eyes aren't properly aligned. And that's called diplopia. So the patient might complain of double vision, and that's because they can't move the eye on the ipsilateral side, the affected side. They can't move it properly and align it with the other eye. Okay, you might see something called exophthalmos. If there's bleeding into the orbit, that blood takes up space, and that might cause the eyeball to protrude a little bit and kind of stick out through the front of the orbit. And so you might have kind of a bulging eye, and that's called exophthalmos, or protruding eye. That's another thing that you might see. And you might actually see the eye is depressed. The eyeball itself might start to fall through this floor a little bit, and so that eye might be depressed relative to the eye on the contralateral side. And so you want to look for that misplacement of the eye where it's depressed slightly. That's also an indication of a blowout fracture. And so when we look at this, just make sure I get all the symptoms there. I think I covered everything. Obviously, pain is going to be a symptom. That goes without saying. Displaced inferiorly, limitation eye movement, double vision. And also, the other thing that we have is a paresthesia within a V2 dermatome. And I'll show you why that is in the next slide. But running along the floor of the orbit is a nerve that's ultimately going to be cutaneous. It's going to pop out through the infraorbital foramen and supply the V2 dermatome of the face. And so you might have paresthesias within the V2 dermatome because that nerve also is falling through this hole right there, and the nerve is being affected. That's the infraorbital nerve. We'll look at that in a second. So the moral story is, a blow to the eye. You want to make sure it might be more than just a black eye. You don't want to miss a blowout fracture because this can ultimately, as you can imagine, lead to loss of vision ultimately if it's really, really bad. Okay, and so here it is right here. So looking at the floor of the orbit again, this is the groove for the infraorbital nerve, and here's the infraorbital foramen. So there's a branch of V2. This is the inferior orbital fissure down here. It's between the maxilla and the greater wing of the sphenoid bone. That's where the inferior orbital fissure is. Okay, we see that from the other side. If you want to know where the other side of this fissure is, you have to go into the infratemporal fossa, actually. And coming through here is a branch of V2. It's going to run along this groove and ultimately pop out through this hole right here, the infraorbital foramen. Once it pops through there, that's the infraorbital nerve, and it's a big nerve supplying the V2 dermatome of the face. And so paresthesias within the V2 dermatome on that side is another indication that there are problems right here where that nerve, there's a hole right here, and that nerve is falling through the hole. Now we go up here, and let's look at some of the other openings here. Again, this is the sphenoid bone in yellow, forming the back wall of the orbit, and we see a crack right here. Well, this is just the other side of that superior orbital fissure we talked about from the point of view before we looked at from the perspective of the middle cranial fossa. Here's the other side of it. It takes us into the orbit. And passing through this thing, superior orbital fissure into the orbit, are cranial nerves 3, 4, and 6. These are the 3 nerves that move the eye around. That's how they get into the orbit, to supply muscles that move the eye. V1, which is the ophthalmic division. Ophthalmic means eye, ophthalmic division of the trigeminal nerve. That's going to go in here as well. It's going to form multiple branches, and we'll describe those branches in a little bit. Passing back through this fissure, going the other way, are ophthalmic veins, which are going to drain the eyeball in the orbit. And we're going to see in a little bit, they're going to drain back to that thing called the cavernous sinus we talked about. We'll come back to that concept in a little bit. Again, this is the greater wing of the sphenoid bone. Remember, I told you the superior orbital fissure is between the greater wing and the lesser wing. And so this is the other side of the lesser wing of the sphenoid bone. And I told you earlier in the last lecture, there's an opening in the lesser wing right there called the optic canal. That's it right there. And passing through the optic canal are cranial nerve 2, the optic nerve, and the ophthalmic artery, the artery that supplies the eye. That's the only thing passing through that hole right there. Okay, so when you think about all the eye-ish things, ophthalmic artery, ophthalmic veins, the nerves that move the eye around, the nerve that's bringing visual information back from the retina, as well as this trigeminal nerve right here that has the word ophthalmic in it, meaning eye. So all the eye-ish things, okay, they're all passing through the superior orbital fissure. All of them except for these 2 guys. If you can just remember, these are the 2 that pass through the optic canal. Anything else that's related to the eye is passing through the superior orbital fissure. You should be good to go. Okay, now let's move on and look at a sagittal section through the orbit and some of the concepts here. This is the location, the eyeball right here, very commonly referred to as the globe. That's the eyelid right there. You see a conjunctival sac right there in front of it. Okay, there's cranial nerve 2. Now, the space around the orbit right here, the walls are lined with a connective tissue called periorbita, okay, which is basically just fascia investing the contents of the orbit. It's actually a continuation of the dura mater, actually. It's closely related dura mater. And then right here in the upper eyelid, there's like a vertical sheet of connective tissue that enters the eyelid right here called the orbital septum. And that's continuous with this periorbita. So in the cadaver, this appears to be kind of a dense, thick connective tissue. And then deep to that, what we find within the space right here, in addition to all the things that we're going to talk about that we find in the orbit, there's just a ton of orbital fat, really, is really what you find mostly in here. And that orbital fat is basically providing a cushioning material for the eyeball and all the contents in here. A couple of things to appreciate here is that, as we've said before, cranial nerve 2 is special in that it's really not a nerve. It's really a central nervous system white matter tract that actually leaves the brain and goes all the way to the eyeball. It's not really a nerve in the traditional sense. It's more of a CNS white matter tract. Okay, so the optic nerve or cranial nerve 2, and as such, it follows all the other characteristics of the central nervous system. It is surrounded. First of all, it's coated with pia mater. That's not shown in the slide, but the surface of cranial nerve 2 is coated in pia mater. And then the whole thing is ensheathed in dura mater. And as always, anytime you find dura mater, directly deep to that, lining its inner surface, is going to be arachnoid mater. And then there's going to be a space deep to that, a space that surrounds the optic nerve, and that's subarachnoid space surrounding the optic nerve or cranial nerve 2. And so it follows all the characteristics, just like the spinal cord or brain, has the same meninges covering it, and the same subarachnoid space bathing it, containing cerebral spinal fluid. And at the very end of this thing, as we said earlier, this is the optic disc right here. That's the beginning of cranial nerve 2. That's the point where all those axons from retinal ganglion cells from all over the retina are coalescing to form cranial nerve 2. Remember, cranial nerve 2, likewise, because it's a CNS fiber tract, if you cut it or damage it, it doesn't regenerate, just like the spinal cord doesn't regenerate. That's it. It's damaged for good. There'll probably be no visual recovery. Now, when we think about the optic disc right here, so when this is looking at the back of the retina right there, all this is vasculature right here. These are all branches of what's referred to as a central retinal artery, which is a branch of the ophthalmic artery that actually enters the optic nerve and then enters the eyeball itself. And its job is to supply the more superficial layers of the back of the eyeball, especially most of the retina, not all of the retina, but a big part of the retina. I don't get too much into the details of the vascular supply of the eyeball because it's complicated and kind of outside the scope of PT. But I at least want you to appreciate this central retinal artery right here. And right here, again, this is a healthy eye right here, and we can see the margins of the optic disc right there. We can see the central retinal artery entering the retina right there in the center of that optic disc. What we can't see are axons from retinal ganglion cells are going here and also exiting through this optic disc. And then right behind this is the optic nerve. As we said, the optic nerve is bathed in cerebrospinal fluid, and that same cerebrospinal fluid that we find in the subarachnoid space around the optic nerve is continuous with the same cerebrospinal fluid we find around the brain, which in turn is continuous with the same cerebrospinal fluid we find around the spinal cord. It's all one big subarachnoid space. There aren't multiple subarachnoid spaces. There are different parts of subarachnoid spaces. There are different cisterns, for example, but it's all one continuous space. And so one of the things we think about there, if we have increased intracranial pressure, okay, that basically is compressing the brain, that puts increased pressure on the cerebrospinal fluid, and it actually obstructs, just that increased pressure on the optic nerve obstructs venous drainage from the retina. And the end result is that you can get edema, basically a buildup of fluid right around here, right at the edge of the optic disc. And that's referred to as papilledema. Okay, basically is edema, excess fluid right here, and that takes this nice sharp margin of the optic disc that we normally see in a healthy retina, and it causes it to be kind of blurry. You see it looks kind of puffy right here, And again, that's a suggestion that there's intracranial disease, mostly likely something causing increased intracranial pressure. So that's a danger sign right there. We don't want to see that. That papilledema is an indication of intracranial disease processes. Okay, and that's what papilledema is. Just look for that blurred edge right there. There's a macula lutea right here, by the way, and right in the center of that is the fovea. Again, that's some distance away from the optic disc. That's the position of maximum acuity right there within the retina. Okay, returning to the fasciae of the orbit again. So there's our periorbita right there, and there's our orbital septum. Now, let's look at our orbital septum for a second. Right behind the orbital septum in the upper lateral corner of the orbit is a little a component that we want to look at. So looking at the eye from the anterior perspective right here, so this is basically if we take all the skin off as well as all the muscles and go right down to the bone right here, okay, and we're looking at right here, this is the eyelid, upper eyelid right here, and there's a vertical sheet of connective tissue right here that spans between the orbital margin right here, the superior orbital margin, this bone right here, and comes straight down onto the eyelid. And this forms like a little vertical barrier right here, just to prevent things from basically going through the upper eyelid and into the orbit there. There's a little bit extra reinforcement right there to protect that space above the eye. Okay. Now, if we remove this orbital septum, and so again, get oriented, this is lateral, this is medial, these are the nasal bones, so the nose would be right here. So we're in the sort of the upper lateral orbital margin right there. And if I were to take away this orbital septum right here and remove it and look at what's behind it and kind of look up under the bone right here, I find this guy right here. So there's the eyeball right here. This guy up here, upper lateral margin right here, that's the lacrimal gland. That's the gland that basically makes tear fluid. Okay, lacrimal fluid are teardrops, and that's going to lubricate the eyeball. So the lacrimal fluid will be basically squirted this way onto the surface of the eyeball. That's where we find the lacrimal gland, posterior to the orbital septum, upper lateral quadrant. All right, let's return to our skull base right here. And again, here's the optic canal right here in the lesser wing of the sphenoid bone. Here's our superior orbital fissure. Okay, what we're going to do next, okay, if we were to dissect the orbit, is that we remove all of this bone right here. This is the orbital plate of the frontal bone right here, and basically take away all this bone right here and remove this. That will allow us to enter the orbit from above. We sort of take a superior approach to the orbit when we study it. And so we get this. So the orbital plate has been removed, and now we're looking down in the orbit from above. And this is what we find. So we find a lot of nerves, for one thing, and we find some muscles. Okay, let's talk about the nerves. Let's go back to the trigeminal nerve right there. There it is right there. That's the trigeminal ganglion. That's where cell bodies of sensory neurons supplying the face and anything else that the trigeminal nerve is sensory to, they live right there. And then we have our three divisions of the trigeminal nerve here. We're going to concentrate on this one, V1. That's the ophthalmic division of the trigeminal nerve. And it's going to pass through the superior orbital fissure, which is right here. It's been broken open, so we can look down into the fissure. And there goes V1 right into the orbit. And immediately it's going to split into a couple branches, one of which we can see right away, sitting right on top here. You remove the orbital plate of the frontal bone, remove the periorbita, that's right underneath it, and the very next thing you see is the frontal nerve. This big nerve right here going all the way to here, so it's from here to here is the frontal nerve, and it's going to bifurcate and form two branches. Now this guy is called the supratrochlear nerve. I'm not going to ask you to know that one, but this other one is more important. This is the supraorbital nerve right there. So frontal nerve gives rise to two branches, one of which is the supraorbital nerve. Actually gives rise to another branch back here, I forgot to mention. This is the lacrimal nerve right there. Lacrimal nerve is going to go this way and supply the lacrimal gland. Again, the lacrimal gland hangs out in the upper lateral orbital margin. So there it is, hanging out above above and lateral to the eyeball right there. There's our lacrimal gland. It has a nerve supply, of course. That's the lacrimal nerve. Okay. Let's see, what else do we have in here? So where does that supraorbital nerve go? So that's a branch of the frontal nerve. And what it's going to do is it's going to run along the ceiling here of the orbit and then pop out through these holes right here. It's either like a notch, that's like a notch right there, or a hole. And usually we call it what it is. We would call this the supraorbital foramen, and this guy is a supraorbital notch. The point is you can have two foramina, two notches, a notch on the right and a foramen on the left, or a foramen on the right and a notch on the left. Doesn't matter. I don't really care that much that you know the distinction. We'll just treat these all as supraorbital foramina. Okay, that one really is a notch because it doesn't go all the way around. Doesn't matter. Point is, what's coming through that opening, that supraorbital foramen, is the supraorbital nerve. And it's basically going to go up into the forehead and into the scalp, and it's sensory to all that skin right there. So this is a big cutaneous nerve popping out right about here. Again, it goes along the ceiling of the orbit, pops out right here, and goes into the scalp. And so that's a branch of the frontal nerve, which in turn is a branch of the ophthalmic division of the trigeminal nerve, sensory to the V1 dermatome of the face right there. Okay, V1 dermatome, remember, is upper eyelid and the forehead. Okay, what else do we find in the orbit? Well, let's look at the muscles. First big muscle we see right here. There's another muscle right underneath it, so we want to be careful, but we're looking at this muscle for right now, the topmost muscle right in the center of the orbit. This guy is not a muscle that moves the eye. This is a muscle that lifts the eyelid. Levator palpebrae superioris, elevator of the eyelid. Which eyelid? The upper eyelid. So levator palpebrae superioris muscle is this guy. This muscle will go out and enter the eyelid. When it contracts, it's going to pull this way, pull posteriorly, and lift the eyelid up. Okay? Its nerve supply is cranial nerve 3, or the oculomotor nerve. So the oculomotor nerve doesn't just move the eye around. Obviously, it moves the eye around because its name is oculomotor. But remember, it also is an elevator, a very, very important elevator of the upper lid. Okay? It basically is an eye opener. Okay? So let's look at the muscles that control whether our eye is open or not, because we've now got our complete set. Okay, eyelid closers are on the right, eyelid elevators or openers are on the left. And we said the muscle that closes the eye is going to be orbicularis oculi muscle. Okay, it's a muscle facial expression supplied by cranial nerve 7. The palpebral part is the part that we actually find in the eyelid. This is a sagittal section through the eyelid right here. Okay, your upper eyelid. This is what it looks like on the inside. Obviously, this is all microscopic. The upper eyelid is incredibly thin, but all this stuff is in there. And we find muscle actually in there. That's the palpebral part. That's the blinker. Of course, running around the outside over here somewhere and going all the way around. I can't do it because we're in a sagittal section, but going all the way around coronally would be the orbital part of the orbicularis oculi, and that's a muscle that closes the eye hard. Okay, so those are the eyelid closers, the two parts, the orbicularis oculi muscle. And then we have eyelid elevators that therefore open the eye. And we already talked about the superior tarsus muscle. That thing is actually a smooth muscle within the eyelid that actually is under sympathetic control. So there's a little smooth muscle in there. When it contracts, it's going to pull the eyelid up this way. Okay, pulls this way, and that's going to open the eye, lift the eyelid. That's under sympathetic control. And then the bigger, stronger muscle, most of this tendon right here, this is all tendon of the levator palpebrae superioris, and that's under control of the oculomotor nerve. And that's the stronger lifter of the eyelid, upper eyelid, and that's gonna open our eye. There's the palpebral conjunctiva right there, of course, lining the inner aspect of the eyelid. And the other thing we want to look at while we're here, while we're looking at the eyelid and sagittal section, is this thing and this thing right here. We've got some glands to deal with. Okay, these are palpebral glands. Generically, there are two different types. There are things we call tarsal glands or meibomian glands. That's this guy right there. And it's going to secrete its oil like excretion right about here, right at the kind of the edge of the eyelid. And then over here, in close proximity to the eyelashes, okay, eyelashes are called cilia. In close proximity to the eyelashes are the ciliary glands. And both of these glands, for one thing, secrete an oil. And that oil, as I said earlier, I talked about the lacrimal caruncle. And these are more glands that secrete a hydrophobic oil that lines the outer edges of our eyelids to keep lacrimal fluid on our eye where it belongs. Lacrimal fluid is aqueous, and it's repelled by oil, and that's what retains the lacrimal fluid on the surface of the eye, unless, of course, we cry profusely, and then it's too much, and it overflows the eyes and runs down the cheek. Now, the other thing to keep in mind about these glands is that they can get inflamed and they can get basically stopped up and inflamed, and that leads to these two things, chalasia and hordeola. Okay, so tarsal glands, when they become inflamed, you have an inflamed tarsal gland, we call that a chalasion. And a chalasion basically is a little inflammatory nodule then that's going to face inward towards the eye. And so these things are really, really uncomfortable because as you move your eyelid up and down, this chalasion is basically dragging along the surface of your sclera, which is an uncomfortable sensation there. So these are very unpleasant, chalasia, but that's basically an inflamed tarsal gland. And then we can have an inflammatory nodule that kind of faces outward, and that's a stye, or more properly called a hordeolum. And that's an obstructed ciliary gland, okay, resulting in an inflammatory nodule facing outward. Point is, I want you to know about these two glands, and I want you to know their inflamed complements right there. Chalasia are tarsal glands that are inflamed. Hordeola are ciliary glands that are inflamed. Okay, let's move on. Talk about more muscles. So the artist here has cut out the levator palpebrae superioris here, so we can look deeper. That's the eyelid right there. It's supposed to be right there. You can see the muscle inserting into the eyelid right there. When this muscle, there's a cut in there, there's the rest of it there. When this muscle contracts, it's going to pull the eyelid up. That's pretty easy to see right here. There's the optic nerve, by the way, cranial nerve 2, coming out of the back side of the eyeball. So the optic disc would be right about here on the inside of the eyeball. And then we've got more muscles to deal with. Okay, right underneath the levator palpebrae superioris and pretty much parallel to it. They look very similar. They have the same shape. They're lying right on top of each other. The difference, of course, is that while the levator palpebrae superioris is inserting into the eyelid, this muscle is a muscle that actually moves the eye itself, and it's going to insert actually into the eyeball, sort of the front upper part of the eyeball, and this muscle is called the superior rectus. Recall that rectus means straight, and so this is a straight muscle of the eye, okay, superior because it's above the eyeball. And there's another muscle underneath the eyeball. It basically does the same thing, same shape, inserts into the same place, but on the bottom of the eyeball, and this guy you can barely see down here, is the inferior rectus. Okay? And then on the sides, we have more rectus muscles. On the lateral side of the eye, inserting over here on the side of the eye, the lateral side of the eye, that's the lateral rectus. And then we have a medial rectus that inserts on the medial side of the eyeball. So we have four straight muscles, four rectus muscles, inserting here, 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 and then if we could see through the eyeball, on the bottom of the eyeball, right about at this point right here, just on the bottom. Okay, so those are the four rectus muscles. Those are 4 of the 6 muscles that move the eye around. We got 2 more to deal with, though. And these are the oblique muscles. Okay, here's one right here. This one's not so straight. Looks straight at first, but then its tendon is going to pass through a little pulley right here and then reflect back this direction. That's his tendon right there. So the muscle pulls this way through the pulley and this way. It ain't straight at all. And this is called the superior oblique muscle because its tendon approaches the eyeball as sort of an oblique direction. Okay, it's not going this way, it's not going this way, it's going at like a diagonal. And it's going to insert ultimately, honestly, it goes all the way out here and inserts on sort of the back side of the eyeball, top side of the eyeball, over on the lateral side. So the top lateral back side of the eyeball is really where this thing is inserting. Okay, that's the superior oblique. And it's passing through something, a little pulley right here. And the word for pulley in Latin or Greek, I don't remember which one, who cares, one of those two dead languages, Okay, the word for pulley is trochlea. Okay, trochlea means pulley in one of those dead languages right there. Okay, and the superior oblique is going to pass through the trochlea, this pulley, and that's how its tendon changes directions, by passing through that little pulley. Now, let's look at this whole thing again, only this time from a lateral perspective. Just to get a different perspective, there's our levator palpebrae superioris there. Okay, eyelid's been removed. The upper eyelid would be right here, and you can see that's where this muscle had been going. Right now, it's just sort of flopping around, dangling, because its insertion has been removed. Okay, let's look at the muscles that move the eyeball around. We got our superior and inferior rectus. Superior rectus inserts on the top front of the eyeball. Inferior rectus goes straight out, inserts in the same spot, just on the bottom of the eyeball. And then we have a lateral rectus inserting on the side. And a medial rectus, again, is going to insert in the same spot, but on the other side from the lateral rectus. Those are the four rectus muscles. And then we've got some oblique muscles. There's our superior oblique running along the medial, sort of upper medial wall of the orbit, passes through that pulley right there, and inserts right here on the back upper lateral corner of the eye right there. That's the superior oblique. And there's the inferior oblique. What it does, it doesn't pass through a pulley. It takes its origin sort of below the eyeball on the medial wall and just goes right out and sort of cups the eyeball from below. It kind of inserts in the same spot as a superior oblique did, but on the bottom instead. That's our inferior oblique right there. And when you look at it this way, it's easy to imagine what these muscles are doing. They're doing a lot of things, but the first thing you should imagine right now is that this muscle pulls this way, this muscle pulls this way. These muscles are perfectly positioned to spin the eyeball around in the coronal plane. So they spin the eyeball like this and like this. So your eyeballs can actually turn. Just think about the coronal section, coronal plane through your orbit, and imagine your eyeballs spinning within a coronal plane. Okay, that's what these muscles do. Okay, very, very important for the vestibular-ocular reflex. If we tilt our head in one direction or the other, our eyeballs have to spin in the opposite direction. There's the trochlea right there. Just to remind you, the superior oblique is passing through that. So let's talk about eye movements. And we'll talk about the actions of these muscles and the nerves that supply them. So there's the primary position of the eye. Again, this is the right eye. This is the left eye. You're facing your patient. You can't get inside your patient's head and look out anteriorly. That doesn't work. So you're facing your patient. Your left is their right, and your right is their left. This is the right eye. This is the left eye. There's the primary position. Okay, and it's pretty simple. Okay, if the eyeball goes out laterally, that's called abduction. Okay, so the eyeball, the pupil is moving away from the midline, that's abduction. If the pupil is moving towards the midline is here, that's adduction. So same concept that we've been using all along for these terms. Elevation is when we look up, pupil goes up. Depression is when the pupil goes down. And then we have this. We have that spinning in the coronal plane that we talked about. So the eyeball, we can't really appreciate what's more subtle, and we don't realize we're doing it, but the eyeballs can actually spin around like this. Okay, this guy can spin around like that or like that. Okay, and this is a rotational movement, and always with rotation, you got to pick a reference point in order to define the different motions there. And the superior, the top of the eyeball, is what we use as a reference point. If the top of the eyeball spins in, so the top of the eyeball spins from here to here, so basically the eyeball is spinning around in this direction, like this, that's intorsion. If the top of the eyeball spins out, okay, so the eyeball is spinning this direction, that's called extorsion of the eyeball. Some books call it internal and external rotation. I find that to be somewhat ambiguous because abduction and adduction are, of course, internal and external rotation in a horizontal plane. It's a ball, for cripe's sake. Anywhere it moves, it's rotating, one way or the other. So intorsion, extorsion really are the proper terms. Okay, let's look at the muscles that move the eyeball and their actions and the nerves that supply them. And we'll just do one muscle at a time. There's our superior rectus right there, inserting right there. Just to get oriented, this is the lateral side of the orbit. This is the midline and medial border of the orbit. And so basically, this is a left eye right there. That's supposed to be a lacrimal crunkle right there. And so what does the superior rectus do? Well, it's basically an elevator and an adductor. So it's going to adduct the eye and also elevate it a little bit. That's what the superior rectus does. The inferior rectus does adduction and depression. It's going to move the eyeball down to this position. So we can see the inferior rectus ghosted in because it's underneath the eyeball. Both muscles are supplied by cranial nerve 3. They're both supplied by the ocular motor nerve. Okay, let's go to this one next. Let's stay with the ocular motor nerve for a second. The medial rectus, pretty simple. You got a muscle that's inserting right there on the eyeball, pulls back this way, it contracts, it's going to pull this way, it's going to spin the eyeball in. And so this guy is simply an adductor of the eyeball. Okay, so we have 3 adductors. Superior rectus is a minor adductor, inferior rectus is a minor adductor. The chief or principal adductor is the medial rectus. Pulls the eyeball in. Okay, also supplied by cranial nerve 3 or the ocular motor nerve. Here's a guy, I'm using a different color to indicate this guy. Here's an exception. Here's a lateral rectus. Action isn't too hard to understand. This guy is, his lateral rectus inserts right there. A muscle contracts, it pulls this way. It's going to pull the pupil out. Okay, pupil goes out laterally. That's abduction. So the lateral rectus is an abductor of the eyeball. It's what we use to look out. Now here's the thing though. Its nerve supply is cranial nerve 6, which is the abducens nerve. And now you can see why it's called the abducens nerve, or some books say abducent nerve. That's fine too. Okay, because it drives abduction. In fact, that's all this nerve does. It supplies one single solitary muscle, does one single solitary thing. The only thing cranial nerve 6 does, it's motor to lateral rectus. And therefore, the only thing that it's capable of doing, the only reason we need a cranial nerve 6 is it's one of the abductors of the eyeball. That's it. That's all it does. Now, we got the oblique muscles to deal with, and let's deal with this one first because it's supplied by cranial nerve 3 or ocular motor nerve. And this is the inferior oblique muscle, and there's its orientation there. It takes its origin off the lower medial part of the orbit and inserts right around here, sort of the bottom of the eyeball, backside of the eyeball, laterally. It's kind of where it inserts. Excuse me. Its actions. So when it pulls, what it's going to do, because it's inserting on the backside of the eyeball, it kind of spins the eyeball in sort of the opposite direction in a way. So because it's coming from the medial side, but because it's inserting on the back of the eyeball, it's going to spin the back of the eyeball in, which spins the front of the eyeball out, which is abduction. So it's by pulling in on the backside of the eyeball, it's basically moving the eyeball out, and so it's an abductor. By the same token, it's pulling on the bottom of the eyeball, but it's pulling on the backside of the bottom. And by doing that, it spins the eyeball up towards us. And so it's also an elevator. Okay, by pulling this way on the bottom backside. Backside is the key. And spinning the backside of the eyeball down, it spins the front of the eyeball up. Okay, and so it's an elevator of the eye. So it's this is paradoxical. Inferior oblique is an elevator. Remember, the inferior rectus is a depressor, but the inferior oblique is an elevator. Okay, and the last thing it does, this is the extorter of the eyeball. So if you want the top of your eyeball to spin out, you need your inferior rectus, inferior oblique to do that. It's the only muscle that's really in a position to spin the eyeball in the coronal plane, this plane right here, and take the top of the eyeball and spin it outward. Okay, it is the chief, actually the sole extorter of the eyeball. And it's supplied by cranial nerve 3. Now, superior oblique muscle, okay, that's this guy who goes through this pulley right here, and he's going to insert right there. Top of the eyeball laterally, but importantly, again, like the inferior oblique, the back side of the eyeball. And so it too is an abductor because it's going to spin the back of the eyeball in, and that's going to spin the front of the eyeball out. It's the front of the eyeball that we care about, not the back side. And so it's an abductor. Okay, it's also a depressor, and again, that may seem counterintuitive there because it's a superior oblique, but remember, it's pulling this way on the top of the eyeball, and so it's going to pull up on the top of the, pull up on the back of the eyeball. That's going to spin the front of the eyeball down, and so paradoxically, the superior oblique is a depressor. It's pulling up on the backside, that spins the front of the eyeball down. And then the last thing, it is the intorter of the eye. By pulling this way, it basically takes the top of the eyeball and spins it inward. Okay? So it is the chief intorter of the eyeball. Intorsion, again, top of the eyeball spins in. Okay? That's intorsion. Okay? It's the only intorter. Okay? Just like the inferior oblique is the only extorter. Okay? Nerve supply. Okay, this is another case where one nerve, one muscle, cranial nerve 4 or the trochlear nerve. And now we see why it's called the trochlear nerve, because it's supplying the muscle that passes through the trochlea, the poli. It's named for the poli, basically. It's the poli muscle, and so it's the trochlear nerve. Okay, and again, like the abducens nerve, this is the only thing it does. Cranial nerve 4 has one single purpose in the universe, and that's motor to the superior oblique muscle. It doesn't do anything else. Okay, now how do we test these muscles? And this is another paradoxical concept. Okay, it's kind of counterintuitive at first, but I'll show you why it works this way in a second. And basically what happens is this. And so just to get oriented, this is the nose over here. So this is the midline right here. This is the lateral side right here. When we test the eye, we're basically going to ask the patient to follow our finger with their eye without moving their head. But there's a very, very specific sequence that we go in. Now, in reality, in the clinic, you'll probably be taught to test both eyes at the same time. That's generally what clinicians are trained to do. When this test was first devised in the 19th century, it was intended to be done one eye at a time, however. And there's a very specific reason why the sequence is exactly what it is. Now, just to look at this ahead of time, you can see why the sequence what it is. First thing we test is cranial nerve 6. Then we test a whole bunch of movements relating to 3, and we end with cranial nerve 4. And that's why the sequence is what it is. But let's look at this. So here's the primary position. First, we ask the patient to look out. That tests abduction and the lateral rectus. Then we ask the patient to look up. Okay, that's elevation and superior rectus, also cranial nerve 3. I'm sorry, let's start again. Start in primary position because I messed up. We ask the patient to look out or abduct. That's cranial nerve 6. We start with 6. Ask them to look up. That's cranial nerve 3 and superior rectus. Ask them to look down. That's inferior rectus, also cranial nerve 3. Go back to the primary position. Look in. That's cranial nerve 3 and the medial rectus. Ask them to look up. Inferior oblique and cranial nerve 3. And then finally look down. Superior oblique and cranial nerve 4. So we start with 6, 3, 3, 3, 3, 4. That's basically the sequence. Now, something odd about this you might notice. Let's see how much of this makes intuitive sense. Asking the patient to abduct, look out. Sure, that tests the lateral rectus. That's pretty straightforward. Now we ask the patient to look up. The test the superior rectus. Now we said the superior rectus is an adductor of the eyeball. We're asking the patient to look out first to test it, and then down to test the inferior rectus, which is also an adductor. Now let's go back to the primary position here. We ask the patient to look in to test the medial rectus. That makes sense. But then we ask them to look up for the inferior oblique, down for the superior oblique. I remember I told you the oblique muscles are abductors, okay, not adductors. So we're going to ask the patient to look in to test a muscle that that drives the eyeball out, which is counterintuitive and causes confusion. Okay, and the reason for this is that, as always, when we test muscles, the rule is that you want to test the muscle under conditions that the muscle is the prime mover, the muscle that's doing most of the movement. And what's happening here is that when we look out, okay, at this position with the eye already abducted, the prime elevator is the superior rectus. Okay, the inferior oblique is actually in a weak position to elevate once the eye is looking out. Likewise, the prime depressor of the eyeball, once already abducted, patient's already looking out, the prime depressor is the inferior rectus. Likewise, we look in, okay, from this position, from the adducted position, the stronger elevator is the inferior oblique. The stronger depressor is the superior oblique. Superior oblique is a stronger depressor than the inferior rectus from the adducted position. That's why we do this. So we test superior oblique using depression, not its abduction. Okay, so normally it abducts and depresses. We're not using abduction to test it. We're using depression to test it. We ask the patient to look in first. Okay, now to understand why this is, this is FYI. You don't need to. This is just in case you're curious why this is. Why we ask a patient to look in and down to test a muscle that moves the eyeball out and down. Why is that? Well, these are the vectors of pull for the inferior rectus and superior oblique muscles. These are the two depressors of the eyeball. Okay, inferior rectus, this is a dashed line right here. This is the vector of pull for the inferior rectus. Line is dashed right here because, of course, the muscle is under the eyeball at this point. And this is the vector of pull of the superior oblique. It's pulling towards the trochlea, which would be right about here. Okay, and basically this is the concept. This is midline. This is lateral. And for depression, okay, we want to pay attention to this light blue line here in the sagittal plane through the eyeball, and we want the front of the eyeball to move down. That's depression. And so the question is, in each position, abducted versus adducted, who's the better muscle? Which muscle is in a better position to depress? And we can see right here, whichever muscle is in a better position to depress is whichever vector is closer to this sagittal line right here. And with the eye looking out first, abducted, we can see that the far better muscle is the inferior rectus. This blue arrow is far closer to this light blue line here than this red arrow. In fact, the red arrow, if anything, is practically perpendicular to the sagittal plane. When the eye is looking out, okay, the superior oblique is in a horrible position to depress the eyeball. It's a great position to intort, but a horrible position to depress. So when the patient is looking out, the more powerful depressor of the eyeball is the inferior rectus. Now, if you have the patient look in first, now this vector of pull for the superior oblique is much closer to the sagittal line right there, much better position to depress, and it's at least as good a depressor as the inferior rectus in this position. So anyway, all of this is just to kind of resolve a kind of a mystery that a lot of clinicians are confused about. Superior oblique, the actions are abduction and depression, but we're going to ask the patient to look in first and then ask them to depress. It's that depression from the adducted position that we use to test it. So it's a paradox, but it's true whether you like it or not. If there's any confusion about this at all, please send me an email and we can work through it. Again, this is FYI. I don't require you to understand the mechanism. I just want you to know, A, what the muscles do. Superior oblique is an abductor and a depressor, but I also ask you how to know how to test it. You ask the patient to look in first, to adduct initially, and then look down. That's how you test it. So know the actions and know how you test it. If you know why and understand why, good for you. If you don't, that's okay. Just shoot me an email if you're confused. Blood supply of the orbit. There's the internal carotid artery right there, sitting right next to the optic chiasm. We've talked about that in neuroscience. Remember, calcification of this artery can compress the optic chiasm, causing a bitemporal hemianopsia. Binasal hemianopsia. I misspoke. Internal carotid artery right here. This is the optic canal right here. Into the optic canal goes the optic nerve, which is right there, but also into the optic canal goes this artery. This is the ophthalmic artery right there. It's going to pass through the optic canal and into the orbit. And then it's going to go up and over. It's initially under the optic nerve, but eventually goes up and over the optic nerve from lateral to medial. That's the ophthalmic artery. Okay, you see right here, this is cool. It's giving rise to a branch right there. It's actually entering the optic nerve. That's a central retinal artery, but most of the artery stays on the outside. Now, eventually, there's a branch that comes off over here. Don't worry about this branch. Okay, there's a branch that comes off that goes out through the supraorbital foramen, and that's the supraorbital artery, and that's going to go to the scalp. Okay? All right. What else do we have here? There's the superior oblique again. So we look at the medial side of the orbit. This is the medial rectus here, but it's way, way down there. The superior oblique is sort of on top of it, right there. And there's the trochlea, and there's this tendon going onto the eyeball underneath the levator palpebrae superioris and the superior rectus right there. Okay? And there's its nerve supply. Trochlear nerve, cranial nerve 4, is going to enter the superior oblique right there, right along its superior edge right there. This muscle, the superior oblique, is a flat muscle just like these muscles are, but it's turned 90 degrees and sort of oriented vertically. And so that thinner edge right there, and you can see the trochlear nerve typically going into that thinner edge right there and disappearing inside the muscle. That's how you identify it. Okay, just look for the nerve going to the superior oblique. And then we go to the other side, and let's retract the lateral rectus right there. And we find a nerve right there entering the deep side, the medial side of the lateral rectus. Well, that's the abducens nerve. That's cranial nerve 6 right there, diving inside the lateral rectus, supplying it. Okay, that's a lacrimal nerve out there. Don't confuse abducens with lacrimal. Abducens is on the medial side of the muscle. Lacrimal nerve stays on the lateral side of the lateral rectus and ultimately goes to the lacrimal gland. And then we got more nerves. Cranial nerve 3, as you now know, ocular motor nerve is going to supply 5 muscles in here. 5 skeletal muscles, actually. 5 striated muscles. Also does a couple smooth muscles, both cystial to striated muscles. So what are they? Levator palpebrae superioris. Okay, we got superior rectus, inferior rectus, medial rectus, inferior oblique. It does a lot of muscles in here. And there it is right there, a much bigger nerve. That's the ocular motor nerve. Okay, the levator palpebrae, easy for me to say, levator palpebrae superioris and superior rectus have been cut here by the artist, but we can see their nerve supplies arising from the ocular motor nerve entering it right there. Okay, and we can see there's a nerve ending up going to the inferior rectus right there, and there's even a branch of the ocular motor nerve going to the medial rectus right there. It's also going to supply the inferior oblique, which we can't see that, but there's going to be a little branch ocular motor nerve that goes underneath the eyeball and supplies the inferior oblique. A couple other things we see in here on the lateral side of the optic nerve, between the optic nerve, which is right here, and the lateral rectus, we find a little ganglion. Okay, this is parasympathetic innervation of the eyeball. We actually have the ocular motor nerve is going to bring in preganglionic parasympathetic axons from Enger-Westphal nucleus. I'm just talking about neuroscience, reminding you of that a little bit. Okay, axons are going to come in here, and they're going to synapse in this ganglion. And within this ganglion, we find cell bodies of postganglionic parasympathetic neurons. Okay, so this is a parasympathetic ganglion called the ciliary ganglion. Axons from those postganglionic parasympathetic neurons are going to enter these little nerves right here called the short ciliary nerves. They're going to dive into the back of the eyeball. Okay, so preganglionic parasympathetic axons via cranial nerve 3 to the ganglion, ciliary ganglion, postganglionic cell bodies, their axons enter the short ciliary nerves, enter the eyeball to innervate 2 targets inside the eyeball. And here they are. We got 2 targets. We've got the sphincter pupillae muscle, which is within the iris, and we've got the ciliary muscle right here. Sphincter pupillae muscle is basically the muscle, when it contracts, it's going to reduce the diameter of the pupil. Okay, so basically it's a sphincter muscle that goes all the way around. Okay, we're in the wrong plane here, I can't show it, but it's going around like this. And when it contracts, it's going to make this, because it's a sphincter muscle, it's a circular muscle, it's going to make this hole smaller. And so this is the muscle that's going to constrict the pupil, usually in response to light entering the eye, more light than is needed, or for near vision. And then here's a ciliary muscle. Okay, that muscle right there is also a ring-like muscle that goes all the way around in the coronal plane. And it's going to be inserting into these little suspensory ligaments right there that go to the lens. And when this muscle contracts, Okay, its diameter, the diameter of the muscle gets smaller. That takes tension off these little suspensory fibers, and that allows the lens to thicken for near vision. Okay, other autonomic innervation is this. Now, I told you about the frontal nerve, which is a branch of V1. It's not shown anymore. It's been removed. It's running over the top of the levator palpebrae superioris. There's also a branch of V1 that's under the levator palpebrae superioris and the superior rectus, and this is the nasociliary nerve right there. It's a nerve that's going to pass from lateral to medial over the top of the optic nerve. Takes the same trajectory that the ophthalmic artery takes, which is not shown here, which also goes from lateral to medial over the top of the optic nerve. Those two things run parallel to each other, nasociliary nerve and the ophthalmic artery. And this is another branch of V1, mostly cutaneous. It's going to be sensory to those ethmoid air cells I told you about earlier. It's also going to give rise to another cutaneous branch that's minor and insignificant. I'm not going to tell you about it. The reason I'm telling you about it is because of these guys right here. Coming off the nasociliary nerve are things called long ciliary nerves that enter the back of the eyeball. And these are carrying postganglionic sympathetic axons. So this is sympathetic innervation right there. And they're going to enter the eyeball to supply one target. And their target is the dilator pupillae muscle, a muscle that's oriented this way, radially within the iris. When that muscle contracts, it's going to make the pupil bigger. And so this is the muscle that dilates the pupil, and again, that's something that happens under sympathetic control. So the pupil will dilate when there's not enough light entering the eye, or for far vision. If we're trying to look out across a long distance, our pupil will dilate to allow more light in. All that's under sympathetic control. Pupils will also dilate when we're scared. The bear is attacking us. Again, the nerve impulses will pass through the nasociliary nerve, long ciliary nerves, causing this muscle to contract, causing the pupil to get bigger. Okay, that takes us back to Horner's syndrome. Okay, don't forget about Horner's syndrome. We lose innervation to that muscle, to the dilator pupillae. Horner syndrome is loss of sympathetic supply to one half the face. So on this side of the face right here, the right side of this gentleman's face, I'm pretty sure that this is a gentleman. Okay, and so what do we see? Well, symptoms that we can't see in this picture right here are flushing, the face becomes red, and that's because the vasculature in the skin becomes dilated. Okay, so again, cutaneous vasculature generally constricts when we get scared. That's why we turn white when we see a ghost. Okay, we don't want blood going to our skin when we're scared or when the bear is chasing us. That doesn't make any sense. We want to divert blood to places where it's more needed, the heart, the lungs, and the skeletal muscles. And so when we lose sympathetic tone to this side of the face, okay, the vasculature will dilate, and that will cause us to turn red. Okay, anhidrosis, sympathetic nervous system is also supplying sweat glands. Anhidrosis is the absence of sweating. And so our skin also becomes dry on this side. Okay, now looking at the eye, the effects of Horner syndrome, loss of sympathetic supply right here, two things. Okay, and I'm kind of working backwards here. I told you about the superior tarsus muscle in the upper eyelid. That's the other elevator of the eyelid. Levator palpebrae superioris is one. It's supplied by the ocular motor nerve. The other one is the superior tarsus muscle. That's under sympathetic control. Loss of sympathetic innervation to the face means this eyelid's going to droop just a little bit. Not a lot, because the levator palpebrae superioris is still intact. But it's going to droop a little bit. And we call this a mild ptosis of the eyelid, or a half-mast ptosis, like a flag at half-mast. Okay, this eye is wide open. This one's closed a little bit. And then lastly, we have pupillary constriction. Again, sympathetic innervation to the face has been lost on this side. Sympathetic innervation drives pupillary dilation. Loss of sympathetic supply means the parasympathetic nervous system is unopposed. That's cranial nerve 3 and the ciliary ganglion and the short ciliaries. They're unopposed, and the pupil will constrict right there. So these, again, are the signs of Horner syndrome, loss of sympathetic supply to one half of the face. Let's talk about other palsies. So what happens when we have ocular motor nerve palsy? So cranial nerve 3 has been damaged. What's going to happen? Well, we think about all the muscles that it that supplies, actually, it's easier to think about the muscles that it doesn't supply. Oculomotor nerve supplies every single muscle that moves the eye except for two, the lateral rectus and the superior oblique. Okay, both muscles are abductors. Okay, furthermore, the superior oblique is a depressor of the eyeball. Therefore, it shouldn't be surprising that loss of cranial nerve 3, leaving lateral rectus and superior oblique unopposed, two abductors and a depressor, the eyeball will be turned down and out. Okay, so the patient will look down and out, okay, with an ocular motor palsy. The other thing is that we lose innervation, or we have weakness of the levator palpebrae superioris, and so we have ptosis of the eyelid as well. Okay, and the last thing is that we've lost parasympathetic supply. Remember, preganglionic parasympathetic axons, ultimately that are intended to drive the sphincter pupillary muscle, they've been damaged, and so the sympathetic nervous system this time is unopposed, and the pupil will dilate. So dilation of the pupil, ptosis of the upper eyelid, eye directed down and out. All of these are signs of an ocular motor nerve palsy, a cranial nerve 3 damage or lesion. Abducens nerve palsy, okay, what are we talking about? We're talking about one muscle, lateral rectus, which is over here and pulls the eyeball out. It's unopposed, meaning the medial rectus and the other adductors, superior rectus, inferior rectus, medial rectus, are all adductors of the eye. They're unopposed by the lateral rectus, and so the eyeball is going to be directed inward. The eyeball is going to be stuck in the adducted position because we've lost a chief abductor out here, the lateral rectus. Okay, so the eye is going to be directed inward. That's typical of an abducens nerve palsy or a cranial nerve 6 palsy. And then a more complicated one is cranial nerve 4, okay, or trochlear nerve palsy. What's going to happen with this? Well, what have we lost? We've lost the superior oblique muscle. Superior oblique muscle is a depressor, an abductor, and an intortor. Don't worry so much about the abduction because we've got plenty of abductors and adductors that take care of everything. But the fact that it's a depressor does cause a problem. So in this woman, the issue is on the right side. Okay, there's our right eye, there's our left eye. And now we have a problem. We have weakness of depression of the eyeball, which causes the eyeball to deviate up a little bit. So you see this pupil is higher than this pupil. Okay, that's called hypertropia, meaning the eyeball is abnormally elevated. Okay, so eyeball is elevated. The other thing we've lost is intorsion. Okay, the eyeball, the top of the eyeball, which will be right about here, cannot spin inward. And so what's going to happen is she's going to compensate with her head, both for the hypertropia and the lack of intorsion. And so what the patient will do very often is kind of point their chin inward. It'd be nice if I could demonstrate this, but the chin kind of goes inward towards the chest. That moves the eye down a little bit by moving the entire head down, and that's compensating for the hypertropia. Okay, if you can't depress your eyeball, then depress your entire head, and the eyeball will come with it. And she's also tilting her head away from the affected eye. What is she doing? She's intorting. Okay, she can't spin the top of her eyeball in, so she's spinning her entire head in to compensate. So this is intorsion by entire head right here. Okay, so that's what the patient will do. They'll tuck their chin in and tilt their head away from the affected eye, and that's a pretty good indication that this patient might have an issue with their superior oblique or cranial nerve 4. Okay, now why is she doing this? And patients will always try to compensate. The patient will say it's because if I don't do this, I see double. Okay, I basically double vision is called diplopia. And diplopia or double vision is something you generally always see when one of the eyes aren't looking in the correct direction. And so this was true of the previous two palsies as well, ocular motor nerve palsy, abducens nerve palsy, trochlear nerve palsy. What all these things have in common is that one of the eyes is not directed in the correct direction. It's not looking where it's supposed to be looking. It's not aligned with the other eye. And when the eyes aren't aligned properly, they end up looking at two different things. And when the eyes look at two different things, we end up getting a double vision. We see double imagery because the eyes aren't properly aligned. And that, of course, is very, very unpleasant. It's weird to start with. And it also tends to result in a bad headache. And so the patient, by the reason she's putting her chin in and tilting her head, is to compensate and to avoid double vision or diplopia. She's trying to eliminate the double vision and the resulting headache. Okay, so that's why they're doing that. And again, that's going to be true of the other palsies as well. The patient will likely report double vision or diplopia. Now let's just end right here by talking about the cavernous sinus a little bit, because it has an intimate relationship with the orbit. And we talked about earlier, there's a cavernous sinus right here. It's a dural venous sinus. You got dura mater here, and there's another layer of dura mater inside. But it's not just your typical dural venous sinus in that all you have in there is venous blood. You do have venous blood in there, but you also have an artery and 5 nerves in there as well. The internal carotid artery is inside, as well as cranial nerves 3, 4, 6, V1, and V2. So all 3 nerves that move the eye around, as well as 2 divisions of the trigeminal nerve, are all either located in the cavernous sinus or at the very least in the lateral wall of the cavernous sinus. Okay, so here's just a close-up of what we're looking at here. And again, most of those nerves we've been talking about going into the orbit are passing through the cavernous sinus on the way there. There's the internal carotid artery right there inside the cavernous sinus. There's cranial nerve 3. Right underneath it is cranial nerve 4 right there. And there's the trigeminal nerve, and V1 and V2 are also located in the cavernous sinus. Better way of looking at it is in the coronal section. So let's look at it this way. And so what we're looking at here, this is the body of the sphenoid bone right here, or at least half of it. So we're basically looking at the sella turcica. The hypophysio or pituitary fossa would be right about here. The pituitary gland would be right about there. And this is actually the sphenoid sinus. That's an air sinus. The sphenoid bone is hollow. Okay, that's just an air sinus. It's lined with mucosal membrane. We'll have a bunch of these air sinuses we'll talk about in the next 2 lectures. But this is the cavernous sinus over here. That's a venous sinus. Okay, blue for venous blood. It's filled with venous blood. Okay, the green stuff right here is dura mater. There's a meningeal layer of dura mater right here. And then, not labeled here, there's a periosteal layer of dura mater lining the sphenoid bone. And like always, between that periosteal layer of dura mater and a meningeal layer of dura mater, there is a dural venous sinus right here, a space containing venous blood. But also, we have 5 nerves and an artery. The internal carotid artery is actually passing through this sinus on their way towards the eye and ultimately the brain. It actually passes through this space right here. So it's weird. We have an artery really within a vein, essentially. And then we have a whole bunch of nerves along the lateral wall of the cavernous sinus in order. We have 3, 4, V1, and V2. Oculomotor nerve, right underneath it is the trochlear nerve, ophthalmic division of the trigeminal nerve, maxillary division of the trigeminal nerve, all lined up from top to bottom in order along the lateral wall. Cranial nerve 3, 4, and V1 are passing through here on their way towards the superior orbital fissure, and then from there they'll pass into the orbit. Cranial nerve V2 is heading towards the foramen rotundum, which is anterior to this. It's heading right for it. It's on the anterior side of the cavernous sinus. That's where he's going. And then within the cavernous sinus, running right along the lateral wall or lateral side of the internal carotid artery, is cranial nerve 6, or the abducens nerve. It's actually inside the cavernous sinus, running right alongside the internal carotid artery. The point is, this is important to appreciate here, that all these things are inside this venous sinus, and there are clinical consequences to this. Because the cavernous sinus is receiving the ophthalmic veins. Ophthalmic veins are going back this way and draining the cavernous sinus. Cavernous sinus is also in communication with something called the pterygoid plexus of veins, which is actually in the infratemporal fossa. When I talked about the infratemporal fossa, I didn't mention this plexus of veins, but they're there, and these guys will drain up into the cavernous sinus. Moreover, you have the facial vein right there, and it, through a series of veins, can drain the cavernous sinus as well. The end result of this is that infections in the face that can be transmitted through the orbit this way, infections down here can be transmitted this way, and again, from the face can be transmitted. Infections all over the face and head can find their way into the cavernous sinus. When they do, you don't just have an infection inside a dural venous sinus, that's bad enough, but it also affects the contents of the sinus, including all those nerves we talked about. And so you can have issues with the cranial nerves passing through it, particularly the abducens nerve, cranial nerve 6. And so you could have an abducens palsy secondary to an infection of the cavernous sinus. And that just leads us to this final concept. And again, this is just sort of a sagittal section through the head. Here's the cavernous sinus here, communicating. You see the communication here of the pterygoid plexus of veins communicating with it. Here's the facial vein. It communicates with these guys directly and also communicates with the cavernous sinus. And the ophthalmic veins, superior and inferior, also drain the cavernous sinus. And there's this concept that many people find kind of incredulous, but I'm obliged to tell you about it. And that's this concept of the danger zone, which is this triangular region right here. And what can happen very commonly is that infections in the face within this triangular region have a nasty habit occasionally of finding their way back in the cavernous sinus. So an infection here in the skin can be transmitted posteriorly, say for example through these ophthalmic veins, okay, or maybe through this route right here and find their way back in the cavernous sinus. And now we have an infection deep inside the head. And it can be, this is the incredulous part, something as simple as squeezing pimples right in here. Usually that's okay, but tampering with pimples right in here, if you push the right way and if there's the right kind of communication involved, some of that inflammatory and infectious debris, okay, can actually find its way back into the cavernous sinus. So, and this can actually cause you to die. Okay, so you can get thrombophlebitis, which is inflammation of the venous system, end up with cerebral edema, so it can actually affect the brain, and you can die from all of this. So don't squeeze your pimples is the point, or you may die. That's the danger zone. And that's the end of this talk. So that's the orbit and eye. Again, as always, let me know if you have any questions. Just shoot me an email. Hopefully this is clear enough.